Thank you very much. Again, thanks for having me. And really, I'd rather hear Dr. Ott speak for another half hour, but I will talk about lung MR. When I mentioned to my friends at Mayo that I was talking on lung MR, they said, well, that'll be a short talk. But then they started sending me articles and inundating me with articles and cases, and I realized that there's a lot there. And not only is there a lot there, but I think it will grow with time. So I'll tell you, I'll convey what I know, what we know, what we're doing now, and try to make a few major points. I have no disclosures. So current practice, pulmonary nodules, CT is really the gold standard. It's what we compare everything to. CT has made tremendous advances over the last couple decades, very ultra-high thin sections, high resolution, and decreasing radiation. For lung cancer staging, CT PET, and for the soft tissue, for brachial plexus, for chest wall, for mediastinum, MR is great, and especially for brachial plexus. What are the limitations of MR? I mean, before I started working on this talk, if anybody had called me, my clinicians, I do pediatrics, and said, I want a lung MR, I'd say, oh no, you don't want a lung MR. We'll do a chest CT, and then, we'll do an MR for these other things, but you can't see anything on lung MR. But I found that I was wrong, and so now when they call me, I'll say different things. So what's the problem? There's low signal to noise due to the low proton density within the aerated lung. There's magnetic susceptibility differences between the air and the soft tissue, so when you get those two together, you get a lot of artifacts that come. And then there's motion artifact. You have the heart beating, you have the patient breathing. Those, and motion is like what you don't want in MR. That's why with kids, we just sedate them for it, because any kind of motion within the series that you're doing will negate the whole series. So those are the things that we have to overcome in getting good MR images. So this kind of demonstrates some of those problems. These are optimized MR sequences through the same plane as this chest CT, and you just see how much more you're seeing, how much easier it is to see with the chest CT. So, why do we even go on with MR? Well, because we want to see what we can see and start developing techniques so we can see more and maybe see things that you can't see on CT. So here's, again, another example of what you're not able to see on CT. This is a little 3 millimeter nodule. Do we care about 3 millimeter nodules? In kids, we only care about them if they've got underlying cancer and you want to look for metastatic disease, and then you just follow them, or inflammatory disease. But so these little things are things we're not going to see, but increasingly we can see larger things. So at Mayo, in 2012, they went back at the end of the year and looked at all their lung MRs and said, how many are we doing? They did 41 cases all year, and that was like 0.3% or less of all the MR studies that were done. So a very small fraction, and they looked at those and thought some of them had been mistakenly ordered and they really didn't want a lung MR, they wanted something else. And then people in thoracic MR radiology decided to develop a small interest group, a focus group, and that's really, I think, what you need in any part of your imaging practice. If you're really going to get good at it, you need a couple people that are going to say, okay, we want to do this. Let's really know the field. Let's work ahead. Let's work with our clinicians. Let's see what we can do, and they develop the practice. So they did, and as any practice, it's not easy to develop it. Over the next year or two, they really are starting to gain momentum on it. And what they're looking for right now are niche applications that will really add unique information on the patient to help in patient care. So they're trying to try different things and see what is really going to be unique and help. So just these are the things I'm going to go through on my talk. Mainly I'll focus on lung and what we're doing, but also some of the other stuff that MR shows, the mediastinum, pleura, chest wall, vessels, and brachial plexus. All right, I think this actually summarizes a lot. At our institution, we have our own proprietary way of pulling up films and looking at them. So in this particular patient, you look at the studies he's gotten. He's had a chest CT, came in from the outside, and then he also had a PET-CT, 698 images. And I guess the other one I was going to show was right up here, but there was a MR sequence, and on the MR sequence, there was like over 2,000 images. So MR sequences typically have anywhere from like 13 to 20 series, and each series will have, you know, anywhere from 30 to maybe even 120 images, so you've got a lot of images to look at. So when you're ordering these on people, it's like, you know, exactly what you need and what's it going to give you besides something else. So again, right now the chest CT and the PET-CT are kind of your two go-to studies, but I think MR is developing. And I just want to go through some of the things that they do in MR. I'm sorry that didn't quite show all the MR. But so these are the advances that are happening. One of the things is dynamic contrast enhancement. And I have to say, this is an improvement over CT. Because in CT, you get usually one, you know, bolus contrast enhancement. If you want to get other ones, you know, you can get a delayed and a delayed and a delayed, but each one that goes through, you add that much radiation. You double your radiation, you triple your radiation, and it's all timed. With MR, there's one dose, it goes through, and you get, you know, very quick sequences. You get them bolus, you get them at 1 minute, you get them at 2 minutes, you can even get them less than that. There's no more radiation, there's no more anything. It's kind of a one-time dose. So with dynamic contrast, you can actually follow something over time, see how does it enhance, how does it wash out, what are the different characteristics. And so that's one advantage of MR over CT. And I think that's developing. I mean, it used to be a time, in the beginning with MR, you got 5 millimeter thick slices, and then it got down to 3 millimeter, and everybody was like, wow, that's great. Will we ever get any smaller? Well, now, you know, for body and cases, we're getting down to 1.5. And with these sequences, we use GE, they're called LAVA. With the LAVA sequences, you get 1.5, and you can get this dynamic study, which is really helpful, and it's used in body, in head, and in chest. Other advances, you know, again, for respiratory motion, for cardiac motion, cardiac gated, is important, is imperative, respiratory triggered, and breath hold. Those are the three things that will negate motion. Do they always work? Not always. Sometimes the heart rate is too fast, sometimes the patient won't hold their breath, sometimes the respiratory triggered coil doesn't work. So those are all things, when they do work, you can get optimal images. And diffusion weighted. I was thinking as I went through this, if there's one thing for me to take away from this talk, think about diffusion weighted imaging. And I'll show it to you because it's something when you first look at it, you say, boy, the patient really moved on that. They really got their series wrong. You don't even look at the images. But as you get used to looking at them, they have a lot of information. And there's something that the MR physicists are hoping will rival PET as far as ability to highlight abnormalities. And so I'll go through some of that. And then fat suppression is something we use in MR all the time. It's one of the nice things on MR. You can get those little fat molecules to kind of negate their signal, and things turn dark, and you can figure out what's fat or what's not, and it's helpful. The big thing it's been used in is adrenal glands. You know, are there adenomas or are they adenocarcinomas? But it's also used for the thymus. And then parallel imaging. We're getting our first PET MR as I speak, and so I think you're going to see a lot of new things come out with that. And I'll talk about it a little bit more, but I think one of the drivers too with MR to replace CT or to at least complement it is the radiation dose with CT. Being in pediatric radiology, it's always a big thing. What is the radiation dose? What does it mean? How, you know, cumulatively, what are people getting? And so I think that's kind of, you know, behind there, kind of pushing MR forward. This is just kind of a synopsis of some of the images and what I'm going to try and go through. Can everybody hear me? I know. All right. Raise your hand if you can. So these images, this is a patient who ended up with a lung cancer, left lower lobe. You can see it down here. This is one of the dynamic images, and I'll show you more of that later. But you can see the really nice contrast enhancement through that. I mean, I think it really rivals CT. The lungs don't, but the mediastinum really does. And so this, and here you can see lymph nodes in the mediastinum. You can see the tumor down there, and you can see the tumor wrapping around the descending thoracic aorta in here and going into the soft tissue. And that's another one of the things that MR, I think, does better than CT is when you get to the pleura, when you get to the mediastinum, you can really see that soft tissue differentiation better on MR than you can on CT. And you can see also with this, there's no motion on it. They really had it gated nicely. This is the PET scan, just to correlate with the CT. Here you can see these nodes light up. They're the same nodes that you're seeing in here. Now this is the diffusion scan, and this just looks kind of like a sloppy image of this. But this actually is showing what we call decreased diffusion. So there's decreased diffusion in this mass, and what that implies, it's not like your regular T2 weighted image where you say, oh, that's edema, that's fluid. That's not what that is. What that is an area where there's increased cellularity and those cells cannot move like they would normally move. They're kind of stuck in this swollen cell. And those light up on this diffusion-weighted images. So when you look at diffusion images, look for what's lighting up. It's almost like a PET scan. You see what's lighting up, well, what is that? It's used in neuroimaging. It's used in abdominal imaging for tumors, for inflammatory bowel disease. It means inflammation. It means edema. It means tumor. It means all those things. But it kind of correlates with the PET-CT. Yeah, and if you talk to your radiologist and you say, I want to see the diffusion images, they will be so impressed. So. All right, dynamic contrast enhanced MR. So we typically evaluate an enhancement over 10 minutes. And so if you look at your series, you'll look for the dynamic bolus, 1 minute image, 2 minute, and 3 minute images. So what that shows you is, you know, again, the arterial phase, the recirculation, how much is something enhancing, and then how quickly does it wash out. With the idea that certain things like malignancies will pick up enhancement quicker, but they'll also wash out quicker. Inflammatory stuff will pick it up quicker, but they'll wash out very slow. And then other things will just have a very much slower normal enhancement with regular washout. And I think those are things with time that are going to be quantitated. So you'll get numbers on them, almost like a MAG3 study for a renal study. All right. So here is some of this dynamic contrast. Again, this shows the images that I did before, just the aorta lighting up, the vessels, and then the tumor. I think I have another better one. Let me just go. Here you go. All right. So this is the bolus, and they sequentially did coronals, axial, coronals, and axials, and I'm not certain why, but I'm certain there's a good reason. I just don't know it. But so here's your bolus image, and it's really beautiful. And I have seen MRAs that are absolutely gorgeous. And one of the interesting things, I mean, you only use a tiny amount of contrast. You can use contrast as opposed to CT that stays in the system for a long time. So you can get multiple series on it as opposed to CT where you've really got one shot like that. With MR, there's contrast that just recirculates, and so you can really get a lot of different imaging. You also use a tiny amount, and you can get tiny vessels. So we've done MRAs on like 2-year-olds, and the surgeons ask for MRAs of their hands. You know, they want the forearms and the tiny vessels in their hands, and you think that isn't going to happen. And it happens, and they're gorgeous. And so for certain things, really, an MRA is going to beat a CT because of different, parameters that we use for it. So consider that. And again, because of the lack of radiation exposure, if that's a consideration for you, I would consider MRA. Just ask the radiologist if this is something that it works well for, or if you should get a CT on it. So this is the very bolus contrast. You can see the kidneys are just starting to light up. Here it is. It's a beautiful look. And then here's the early, this is the 1 minute phase, and so again you can see the aorta is enhancing more than the tumor over here, but you're starting to get an idea of how much does that enhance or not. This is the next coronal image, and you're starting to see a little bit of washout. You can see it's washed out of the aorta, it's starting to wash out of the tumor, and then so this is 2 minutes and this is 3 minutes. This actually I think is a better look. You're starting to see the aorta and the tumor kind of equal enhancement, so it's kind of wash out. And you can take that out to 10 minutes. And again, I think people are going to be looking at that. What does that mean? What does that imply for that tumor, for that mass? So these are some of the things that you can do with MR. Again, parallel imaging. This is the PET scan and the MR scan, just showing the uptake this area. But you can see how well that you can use both images together. They correlate. You're not kind of guessing, is this at the same area or not? Really, the resolution in MR has just really improved so much. So here's that diffusion image, and I'm going to show you again. So This is the enhanced image with the mass here, and this is the diffusion. And so you have this kind of blob of increased T2 signal. All right, now I'm going to go into a little bit of physics that my physics friends have shown me. So if you have coffee, I would drink a cup of coffee, and because it might be a little bit boring, but anyway, I'll do my best. So diffusion-weighted MR involves motion of water within the tissue. So you have these sequences that go by. Here's these little cells, and they've got cells in them, and these can move around freely. So it's called free diffusion. And then diffusion gradients suppress signal from protons undergoing unrestricted diffusion. So these little protons, if they move around, they're going to be suppressed. And so you're going to see dark signal. But if they're not suppressed, if they're restricted, so in some disease, in any disease, in tumors, in inflammation, in anything, if they're restricted, then they're not going to be suppressed, and they're going to light up. So that's the key thing. And so here's some images, and again, at your institution, you have to have somebody that's a real proponent of developing this diffusion-weighted imaging. So we have a few people that are really pushing it, and they would like to see it just really compete with PETCT, again, because of the radiation. And so here's the PETCT, and here's the area of abnormality. This is a patient with metastatic disease. It's PETCT, I'm sorry, over here, metastatic disease. And this is the diffusion-weighted image. And so you see they're very similar. And there's a lot of ongoing studies in the literature, again, about comparing them. And some people think they compare very well, and other people think that the diffusion studies are not yet as good as the PET. But we do have, just in our institution, I'm sure that people do, cases where the PET-CT was negative, like here, and where it's positive on the diffusion-weighted images. So these were liver metastasis, and you don't see them here, and basically because there's increased metabolic activity in that liver, so it would mask it. But there are times when the diffusion-weighted images will show something the PET-CT doesn't. So I think, again, as this develops, people are going to be using it more and more. So again, it's high cellularity and swelling in an intact cell membrane, and that's where you get increased signal for that. The differential, again, is broad: inflammation, ischemia, tumors, metabolic disease, and trauma. But if you have somebody, with a tumor, with a known tumor, I think it's very good to use and see it. The other thing that people are working on is, can this diffusion-weighted imaging be used as a biomarker for predicting response to therapy or not? And I think that that's ongoing now, and you'll see more about it. Diffusion imaging is not sensitive for small pulmonary nodules, so anything less than 5 millimeters, you have a less than 50% chance of picking up, but over that is like 86%. But again, it has to be in good hands. It has to be with people who really know the technique, how to use it, and how to read it. So again, it's developing. All right, MR for mediastinal invasion. Again, it's better, I think, than CT for showing invasion. This is a right middle lobe cancer, and it's invading into the fat in the pericardium. You can see it right here, and this shows it just better than MR is going to show it, this extension. Just multiple examples of that. Metastatic disease. We're seeing it more in kids. More and more people don't do CTs in kids, and they'll just jump right to MR. I'm always amazed. I'm like, where's the CT? Because we still do a fair amount. And it's like, oh, we don't do CT. We just go right to MR. I was just at a meeting for the University of Michigan, and they do all their appendicitis on MR, which is amazing. They do emergent MR for appendicitis very quick. I'm like, how do you do that? So I think you're going to just see, and I see in kids, just like, can we do it on MR? And then they're going to try it. So this is a very interesting case of a one-year-old child who had a mesoblastic nephroma in the right kidney, and those are usually things where, they present near birth, you resect them, and they do fine for life, and never have a recurrence. And this child actually showed up 8 months later with this large right upper lobe mass, very vascular with a lot of enhancement. The MR really showed it well. It abutted the fissures, abutted the mediastinum, and that was a metastatic mesoblastic nephroma, which is kind of an amazing case. But they didn't do a chest CT on him. And So our lung people are starting to work with looking at looking at inflammatory disease too of the lungs with MR. And again, these are dynamic sequences just showing a case of sarcoidosis, just the inflammation, the nodularity, the semiconfluent infiltrates. And again, it's especially around the mediastinum and the parahilar region, it's really a nice look. You're not seeing farther out into the periphery, so again, that's the limitation of it. Some mediastinal cases. So this is one we're going to talk about chemical shift and in-phase and out-of-phase imaging. So if you look on MR series, a lot of times you'll see I and O, or in-phase, out-of-phase. That's what this is all about, and it's all about is there fat in tissue or not. So this patient had a CT for something unrelated, and they saw this. They thought this was kind of like I think they were 27 years old, and they thought the thymus was a little bit prominent. For me in pediatrics, I'm like, oh yeah, we see that. But anyway, in the adult practice, it's probably a little bit prominent for a 27-year-old. So this is the in-phase, and this is the out-of-phase imaging. So the in-phase you see here, there's high signal in there, and is that fat, is that something else? And then you do the out-of-phase, and that all becomes dark. And that's because there's microscopic fat within the thymus, and they do these at the same time, so they're in the same sequence. They get this image early in the sequence and this image later. And so at this point, the fat and the water are opposed to each other, and it drops out. So you get the signal dropout. And so when you see that signal dropout on the out of phase, it means there's fat in there. And so if there's microscopic fat in there, that's going to be a normal thymus. And so that's what that is. In phase, out of phase, dropout, there's fat in it, it should be benign. It's the same thing for lung hematomas. It's the same thing for adrenal adenomas. You never thought fat would be that interesting, but it is. So this is just another slide from one of my physics friends on in and out of phase imaging in MR. But this kind of shows that this is a nice example just in the liver. So this is in phase, and you see it looks, normal signal intensity, and then you do the out of phase, and you see it becomes dark, and that's because there's fat in there. As opposed to the spleen with no fat, it looks about the same. And then you say, well, look at all that subcutaneous fat, that's still bright, that still looks, high signal. It's because it's for like this microscopic fat that's mixed with water in tissue, so it's a different kind of fat. Okay, so basically, basic definition of chemical shift detects microscopic fat. Okay, so here's another case of a thymic cyst. So this is another patient that came in, and this was a CT, and they had this low density, but not real low density, not as low as water, a little bit higher than you'd expect. And it's kind of a lobular contour, anterior mediastinum. This patient was a little bit older, I think 40 or 50. T2 weighted image, bright. And then after contrast, really no visible enhancement at all. And then here on in phase and out of phase, so they look basically the same. So you don't get that dropout signal, so there's no fat in there, so it's a thymic cyst. So no enhancement, high in T2, no dropout on in and out of phase, so it's consistent with the cyst. A thymoma. So this is different. So this is the T2 weighted image. You can see this inhomogeneous enhancement. T1 weighted image. It's low density here. Here we have this is the regular, I think, T2, and this is with enhancement. You can see a little bit of enhancing in there, but this is the diffusion weighted image, and there's nothing that drops out of there. There's nothing that lights up on that at all. So it was thought to be kind of a solid mass, not very cellular, and it ended up being a thymoma. Lymphangioma. So this is just another mediastinal mass, this inhomogeneous area of increased T2 weighted imaging. You can see here it's very irregular and lobular, anterior mediastinum. And again, you can see how MR really shows the relationships nicely to everything. And this is after contrast, just a little bit of enhancement around there. And then here on T2 weighted images, or on the diffusion, there's no enhancement at all in that, and that ended up being a lymphangioma. So other kinds of mediastinal tumors, these are ones that I see. This is a large mass in a 1-year-old that was a neuroblastoma. Again, the MR really shows it well, the relationships. Here you can see it going into the neural foramen. That's another real advantage of MR that you don't see in CT, or it can be difficult to see in CT. It's not highly sensitive. And here again, you can see this large tumor going into the neural foramen on that. So that was a neuroblastoma. The pleura. So this is a Pancoast tumor, and this is one of the things I think, this was a MR for the brachial plexus, but we also saw pleural involvement and bone involvement very well. So this was the Pancoast tumor. Here's the rib. This is actually one of the models that we did, and you can see the tumor involving the rib, involving the pleura. There's enhancement in it, so that really is a very nice look at that. And that's another image of that. So I think for the chest wall, for the ribs, MR is really better than CT. So this is a case of a mesothelioma. Nice T2-weighted image. There's multiple masses in the pleura. You can see them there. This is the diffusion-weighted image, and the other masses don't light up, but this one really lights up a lot. And so it would be analogous to the PETCT. It's a focal area, and that was a malignant mesothelioma. And this is kind of a subtraction image of this. It's called an ADC. It actually takes the brightness and reverses it and to see if it's real or not. And so that was positive for diffusion. So chest wall. These are ones that we see in pediatrics and also in the adult population, but sarcomas of the chest wall. This is a very large lobular mass invading the chest wall, growing out of a rib. You can see it coming up along the spine, pushing the diaphragm down, and those are all very nice characterization, very well defined. It's cystic, it's solid, it's enhancing. It's just a nicer look, I think, than we could get on CT. So vessels, this is something that MR does great. They have all the MRA sequences that you can run, we get some beautiful images. So this was a right aortic arch in a child. You can see it here and coming down here. The only thing I would say on this for children, under 5, you do a lot of anesthesia for kids. If you can get MR goggles, that's great. It really cuts down on your anesthesia. I don't know if any of you do pediatrics, but there's maybe some of your adult patients would like it. MR goggles, they show movies, and they really cut down sedation. I mean, I always think cartoons are like sedation for kids. They just, they just don't move for a while while the cartoon is on. But anyway, you have these MR goggles, you put them on an MR, and you can really decrease the amount of sedation that you need. But otherwise, if you do use anesthesia on kids, there's more coming out in the literature about the potential detrimental effects of anesthesia on the developing brain. So our anesthesiologists are really worried of doing, if they can put off an elective procedure till the child's a little older, they do, especially in the first couple months of life. They really don't like to use anesthesia if they can avoid it. All right, this is another MRA with a patient with hereditary telangiectasia, and it just shows the AVM really nicely. In that left lower lobe. Pulmonary embolus, I think this was just picked up incidentally on this patient. So you can see the thrombus right here in the main pulmonary artery coming down in the lower lobe pulmonary artery. The other thing to consider about is sometimes when you have patients with high creatinines, but they're not so high that they can't have gadolinium, and then we'll do an MR with gadolinium instead of a CT with IV contrast. This was a very interesting case of a sarcoma that was extending into the pulmonary arteries. This patient looked like they had pulmonary embolus, extensive pulmonary embolus, but when it was biopsied, it was actually a sarcoma. So the brachial plexus is the brachial plexus, if you want to see it, you do MR, and this was another case, I think, that we made a model from. And here you can see on the sagittal images that the tumor is really encasing the second and third rib and the thoracic nerves that come right below it. So this was just a nice gadolinium enhanced image here, and this is the coronal image, and again you can see it coming down into the pleura and up to the rib. So, all right. So there's a lot of papers out there, and a number of them tend to come from Japan. I think the most advanced work is coming out of Japan, and then Korea, and more is starting to come out of the United States. But people that are really looking at it and doing these meta-analysis feel like really, if you look at contrast-enhanced CT, contrast-enhanced MR, and PET scanning, there's no significant difference. But one of the caveats with this is MR with diffusion. And it's also contrast-enhanced studies. So they're not non-contrast studies. They're contrast-enhanced studies both for CT and MR, and then they're MR with diffusion. If you don't have the diffusion with the MR, it is not as sensitive as PET. But if you have diffusion with the MR, with enhancement, it will rival PET. So I think you're going to see more and more of that coming out. And again, because of no radiation with the MR, that's something to consider. So what else besides radiation? Contrast. So CT contrast is iodine-based, and I'm sure you all hear about reactions. There are allergic reactions, there are cardiogenic reactions. People can die from it. It affects renal function. With creatinine above a certain level, you just don't give it. But how about gadolinium? Well, in the beginning, people thought it is safe, which is what everybody thinks when you're first starting to use something. It's safe until you start using it enough, and then things happen. And so then, yeah, there were reactions with GAB, but they weren't as much. But then there was renal fibrosis that developed in patients, and those patients tended to have decreased renal function, so we became much more vigorous at looking at people's renal function before they got gadolinium. But there's also a paper just came out from Mayo, but there's other work that was done before that they started noticing on head MR areas of T1 high signal in certain areas of the brain in some patients. And when they looked back, it ended up that those patients had gotten gadolinium. And so did that correlate? Was it from that or not? I mean, they were just tiny areas. And so they just did a study at Mayo, and it was prospective, and they were doing patients with brain cancer. And they took the ones and did autopsy specimens of them and looked at that area of high signal, because the question was that gadolinium or was that something else? And it was actually gadolinium. So they had control patients who had never had gadolinium, and then they had patients who had had it, and then when they died, again, they took the brain to autopsy, they looked at it, and in fact there were very tiny amounts, but tiny amounts of gadolinium in the brain of people who'd had it, and none in the people who hadn't had it, and it wasn't based on renal function at all. All the people had normal renal function. So that, I think, is something you're also going to hear about. I mean, sometimes it's, no matter what you pick, there's CT, there's radiation, there's MR, there's anesthesia, there's gadolinium, and so you just have to kind of make your best choices going forward. But I think that will come out in the literature. I mean, it's coming out in the literature, and you're going to hear more about it. All right, the other thing to consider is time to image. CT, 5 to 10 minutes. I mean, actually when you scan, it's almost like a chest x-ray. You can go through there in a minute. It's very quick. MR is 45 minutes, and a PET CT is 2 hours. So those are length of stays. The other thing for MR is a lot of the images you have to hold your breath. And do you have a patient with their lung function that can hold their breath adequately enough to get good images? And in CT, that really, they just have to hold it for a couple seconds and they're fine, but MR is something else. All right, radiation. This is just shows you what you're talking about with radiation. These are average doses on an average size adult, and if you talk to a physicist, they'll tell you there's this range, there's all these parameters that come into effect, and so people, after they have imaging, always want to say, well, what was my dose? Well, there's so many considerations that you can give them a range, but it's very difficult to say this was your exact dose. But anyway, you can see a chest x-ray, 0.1 millisieverts, and that's the effective dose. That's how we count it. Chest CT, a regular chest CT with IV contrast is 7 millisieverts. We've developed, and everybody has, low-dose chest CTs. We use them for kids that were only looking for metastatic disease. For a while, our pediatric hematologists, oncologists canceled all their chest CTs and just got chest x-rays to look for metastatic disease. And we're like, well, do you want to see it or don't you want to see it? If you want to see it, you got to get a chest CT. But then our physicists really worked, and we're lucky with the lungs because you can get the dose really low and still see pulmonary nodules. So our dose is pretty darn low. It's 1.4 millisieverts for our low-dose chest CT. That's without contrast. We don't, we just say this is not for the mediastinum, it's not for the chest wall, it's for pulmonary nodules, but we're all happy with it. Everybody's happy with it. And then the PET scan, that's 14 millisieverts. So that, is the dose of radiation, and if you get multiple, PET CTs, that's a dose. So just to consider that when you order things. So advantage of MR, there's no radiation. Sequences are being developed to detect and characterize pulmonary nodules, and I think you're going to see more and more of that. Again, a lot of it is coming out of Japan and Korea right now. It's got greater contrast resolution than CT. It's more sensitive for invasion of the mediastinum, pericardium, pleura, and diaphragm. Again, that's just a synopsis of what MR can do. Future of MR, it really is going to be up to the field to advance it. It's happening. I think that you're going to see more and more sequences. They're going to be refined. I think you'll probably see shorter imaging times. And so right now, I don't think it replaces PET-CT at all, but I think it can complement it in some cases, and in some cases can substitute for it, depending on other considerations. So I want to acknowledge Dr. Christine Lee and the thoracic group at Mayo and Radiology, because they really inundated me with these articles, and I appreciate it, and I want to thank you very much.